Right bundle branch block characterizes as conduction block in right bundle branch and so delayed activation of right ventricle. Because activation of left ventricle is normal, initial portion of QRS complexes remains unchanged, but terminal portion widens. Typical QRS pattern in lead V1 is RS-R' pattern, which initial R is smaller than the terminal R. In addition to QRS changes, secondary STT changes are also seen, with inverted T waves seen in right pericardial leads, but T waves are upright in left pericardial leads. We have three examples of QRS and T wave changes after right bundle branch block. On the left and right hands, you see inverted T waves both in V1 and V2. On the middle, there is inverted T in V1, but T wave is upright in V2. It shows upright T wave in V2 can be a normal variant, but V1 typically has inverted T wave in right bundle branch block. Here you see two ECGs of right bundle branch block which were obtained before and after chest pain episode and non-ST segment elevation myocardial infarction. You see upright T waves in left pericardial leads on the left hand, which are inverted on the right hand. In addition, you can see partially flattened ST segment in V1 and V2 that can be due to underlying ischemia. Here you see ST segment elevation and markedly upright T waves in all pericardial leads. Also, Q wave formation is initiated, and after some hours, you see typical evolution of MI pattern and Q wave formation on the right hand. Here you see two cases of right bundle branch block which have upright T waves in right pericardials. On the left hand, the patient has a true posterior MI, but on the right hand, the patient had no evidence of coronary artery disease. It shows that also lack of T inversion in V1 and V2 can show CAD, but it should be confirmed by echocardiography and clinical findings. Here you see two ECGs of the same patient with a couple of hours interval. On the left hand, you see myocardial infarction of anterior wall that has persistent ST segment elevation and Q wave formation of the pericardials. On the right hand, you see secondary STT changes and Q waves in the presence of right bundle branch block. Because right bundle branch block was secondary to anterior myocardial infarction, left anterior descending artery occlusion is probably at more proximal part and left ventricular ejection fraction is markedly reduced.